This is Jerry Hesch from the Hesch Institute in Aurora, Colorado. And my client is coming here from Oklahoma. And he presents with lumbopelvic pain bilaterally and symptoms of pudendal neuralgia. There is a common pattern that I find with patients who have pudendal neuralgia. Now, not all of them present with this pattern, but a fair number of them do. And this is a pattern that I discovered long ago, and I described it and developed treatment for it. And I call it a lower windswept pelvis movement dysfunction. Okay? And what I find in this pattern is it usually consists of a rotation of the left pubic bone in which the lower part of the pubic bone is posterior compared to the right. The upper third is symmetrical, the middle third is symmetrical, the lower third is posterior. So I call it a posterior rotation at the pubic bone, pubic joint. So in doing so, it's going to move this lower part posteriorly, and this is the ischium, okay? So when the client is laying on their stomach, then this flat part of the ischium is more posterior towards the ceiling, more prominent. Now, in my model, we do pay attention to posture to a degree, but the most important question is, how does it function? And joints have a normal spring and recoil movement. And when I test anterior spring on the right ischium, we have movement. So I come down below the sit bone, called the ischial tuberosity, and then I put the heel of my hand on the flat part of the ischium, and I'm pushing straight down towards the floor, and I push, and it moves a little bit and then becomes tight, and then I can thrust it with the same amount of force, and it bounces forward and springs right back. And that force goes through the SI into the hip and down to the lower extremity. I see his heel move when I do the spring test. On the left side, I can't take up the slack. So I'm putting a lot of force and there's no movement. And when I try and spring it, there's no movement. Okay? So that is treatable. The other thing that I find is that when I palpate just inside the sit bone on the right, he's about 2 thumb widths away from the midline crease of the buttock. When I palpate medial to the left sit bone, he's about 1, 2, 3 thumb widths away. Okay? Now again, we concern ourselves with movement. And I've done other movement testing such as superior glide and inferior glide and forward rotation and inferior glide. And when he was laying on his back, we did posterior rotation and we did side glide springing. All of those movements are normal. However, when we come to the lower pelvis and I try to spring the ischium, the left sit bone medially, it doesn't go. And when I try and spring the right one, it doesn't go. So both of these are at end range, okay? And they do not spring medially, and they do not spring laterally. Okay? And that's treatable. Oftentimes I improve symmetry and restore normal mobility, but sometimes there is a little residual asymmetry. But if movement is normal with the spring test, then I know that that's a developmental asymmetry. So my goal is not necessarily to create symmetry, but my goal is to create normal movement. Now, what does this have to do with the pudendal nerve? Well, part of the trajectory of the pudendal nerve formed by the lower sacral nerves is that nerve goes between the sacrotuberous ligament and the sacrospinous ligament. So it's possible that that nerve got traumatized at that level. And the right sacrotuberous ligament comes down from the infralateral angle of the sacrum, this little flat portion, also called the ILA. Okay? So the sacrotuberous ligament goes from there down to the medial aspect of the sit bone. All right? So when I find that ligament, I can indent it on the right side. And now I'm finding that ligament on the left side, and it's really tight, and I cannot spring it. Okay? So that affirms my belief that he had a traumatic shift of his lower pelvis. If the springing was normal in the ligaments, and if the movement was normal, then that would simply be a developmental asymmetry of the lower pelvis. Now the other ligament that I tested is the sacrospinous ligament. And on the right side I can spring it. Maybe you can see a little bit of indentation going on with my thumb. And on the left side, I'm on that ligament and I try and indent it and it doesn't spring. And it makes sense that the sacrotuberous ligament goes from here to here. And so if this is lateral, if this is pushed to the left, then that ligament is stretched. And so is this ligament that connects there. The other thing that I find with this pattern is a side bent pattern of the coccyx. So my right index finger is higher up in relationship to the left, and I'm pushing, it's at least a quarter of an inch higher. Now if I put my thumb onto the left side of the coccyx and then I try and spring it to the left, I'm using considerable force and it's not moving. If I come over to the right side of the coccyx, now I get a little bit of spring. So I can actually make the coccyx go a little further into left side bending, but it appears to be stuck in side bending, and it can actually go a little bit further that way. It just can't come out the other way without a prolonged passive force. When I treat the pelvis, I use a long duration of force application. And what I'll do is film how I will treat him in the next video. And in the third video, I will show how he responds to treatment. Now, when you have an asymmetry in the lower body, the body compensates with an upper body asymmetry in the other direction. And what I'm going to do is have him lie on his back, okay? And I'm not going to film his face, okay? Let's have you lie on your back, please. And earlier I tested his upper body, but I did not test the upper cervical spine. And so I'm testing upper cervical mobility, and he rotates to either side freely. But here's what's interesting. I can easily side bend his head at the first joint. I'm just pushing on, lifting up on the mastoid process, and I can side bend his head to the left. And now I lift on the right side, and I can't spring it. Okay, so his upper body compensates for that pattern by side bending the upper cervical spine to the right. And that upper cervical pattern should resolve spontaneously when I restore normal movement in the lower body. So I will stop filming now. Thank you.